what are the risk factors or predisposing factors for penile cancer? HPV infection is probably the most important factor which determines the risk factors of penile cancer. Other than that, what I discussed like phimosis, lack of circumcision, etc., and a few diseases of the skin of the penis. So, some diseases of the skin also are predisposing to penile cancers like chronic inflammatory balanitis or lichen sclerosus, such diseases. What pathological type of cancer affects the penis? Most common is squamous cell carcinoma. 95% or possibly more cases are affected by squamous cell carcinomas. The remaining varieties are verrucous, basaloid, all these things you will read in your textbook. So, I want to give you a clinical idea about how to encounter and how to proceed in such cases. So, these patients are usually shy to disclose their problem. They are having two types of problems mainly, either a growth on their penis or an ulcer of the penis, mostly due to either because they are shy to disclose to the doctor or they have reached some other form of allied medical practitioner who thinks this is a normal disease and tries to treat them. These diseases gradually, although they start as a small lesion, they gradually become something very big, fungating and disfiguring lesion. So, they are either an ulcer or a papillary mass on the penis. Initially, they are a painless mass. They may be associated with swellings on the groin which denote the lymph nodal swellings. These masses or these ulcers get infected, they become foul smelling. Once they get infected and foul smelling or they get big enough, they start to bleed, they start to itch, and then eventually you see the first picture is an initial picture. The first on the left is an initial picture about of how it might start, and then progressively if the patient chooses not to treat himself, it progressively grows to something like this. We have frequently operated on patients who have come with such a huge disfiguring problem of their genital region. So, counseling of the patient, counseling of your patients to disclose whatever small problem, if it is related to the, if it is either an ulcer or a wart or a fungating mass. What is important is if the patient comes to your clinic with a problem and a hesitant attitude regarding a problem on the genital region, make sure you examine the patient, and you examine the patient by retracting the preputial skin of the glans so that any hidden or latent tumors are also disclosed. You see in this patient, this is actually just behind the glans, which is actually covered by the preputial skin in normal examination. So, physical examination is very important. So, a patient comes to you with either of these kind of a lesion. What to do next? How to proceed? So, what is your differential diagnosis and how to proceed? This penile cancers, if it is available at the time of your examination, it is often given as a short case. It is very frequently given as a specimen for your examinations. So, in spite of it being a comparatively rarer disease, it is very important for your examinations, for your final surgical examinations. So, a patient comes to you with such a presentation. What to do next? First is you have to think out what it can be. What can it be? It can either be viral warts. Yes, it can be viral warts, it can be condyloma acuminatus, it can be precursor lesions like what we just mentioned. It can be a carcinoma in situ variant of penile lesions, which when affects the body of the penis, it is whatever carcinoma in situ, and lastly it can be a malignant disease of the penis. Okay. So, how do we know, how do we decide, or how do we diagnose what variety of it is? So, we have to take a biopsy from the lesion. Okay. So, taking a biopsy from a superficial lesion, it has a very important concept. The idea of the biopsy, especially in many skin lesions, including lesions of this penis, is that the biopsy result should not just reveal the histopathology of the disease. It should also reveal to what depth, to what extent of the organ the lesion has invaded. So, we call this biopsy a wedge biopsy. This is a very important concept, and you will probably be asked about how you will take a wedge biopsy if you encounter such a case. So, you see there are two types of triangles related to the lesion that we see here. Do you see? Do you understand? So, one triangle is broad and shallow, the other triangle is narrow and deep. So, which one do you think will give a better representation of the disease? Please concentrate. Which one do you think will give a better representation of the disease? Why is that? Why is the narrow one going to give a better representation? Very good, very good. So, there are two aspects to a wedge biopsy. One is it should cover the depth of the involved skin or involved superficial structure. The depth of biopsy should be good enough to involve the full thickness of the diseased part, and number two is it should involve a part of normal tissue as well. So, taking out a bigger part of the suspected tissue is not a good biopsy. Then we have this is a representative picture. Okay, this idea of this picture is to make you understand the importance of this depth. I want to know whether this lesion is up to this level or this level or this level, whether it is involving this part of the skin, this part of the skin. That is important. The level of invasion is important. That is what I wanted to show in this picture, that a broad and a bigger tissue chunk is not always good. I want a part of a normal tissue and I want the depth of the tissue, right? And this is a cross section. This biopsy will extend like this on either side. This is the cross section of the biopsy that we are taking. So, this is a biopsy. The expected results from a penile biopsy should reveal the nature of the tissue, whether it's malignant or not. If it is malignant, then whether it is a squamous cell carcinoma or any other variant of the tissue. If it is a squamous cell carcinoma, then what is the grade? What is the grade of the lesion, whether it's a high grade malignancy, whether it's a low grade malignancy, so on and so forth. Plus, it should give us an idea regarding the depth of invasion of the tissue. So, this biopsy report will give us the T part in the TNM staging protocol for cancers, right? Now, after getting a biopsy, we now probably know that this patient is having a malignant lesion of the penis. Now, we have to look for local spread and distant spread. So, according to obvious protocols, we utilize ultrasound of the groin region to check for nodes in the inguinal region, and we also take help of CT scan or MRI to look for local invasion and distant spread, presence of lymph nodes, and PET CT is reserved for patients with suspected metastasis. Okay. So, now something about the lymph node spread. So, the penis is a cylindrical structure. Okay. So, there is intercommunication of lymph nodal channels all over the penis on both sides to the groin. So, a penile lesion may be occurring on the right side of the penis, but that does not mean that only the right groin will be affected by the spread to local lymph nodes will be limited to the right side. That is not true. So, any penile lesion can spread to either of the groins. Now, the lymphatic structure of the penis and its spread to local and it's the normal anatomy of the lymphatic structure of the penis to the local groin nodes is very interesting, and it is important for your examinations as well. What are the electrons of nodes that come one after the other? So the to be very to give you a bird's eye view, the lymph node channels first reach, the first node that it reaches is called a sentinel node. That sentinel node is usually located 2 centimeters below and lateral to the pubic tubercle, usually. But the sentinel node is designated as the node where the first cancer cell reaches for local metastasis. And from there, the first level of spread is to the superficial group of inguinal lymph nodes. From there, the lymph nodes spread to the deep group of inguinal lymph nodes, and from there it spreads to the pelvic group of nodes. So it usually does not skip this chronology. It follows this chronology, and that knowledge is important for the further treatment planning of this patient. So now we know how to take a biopsy. This biopsy concept is very important. Many people, even after passing general surgery, it's not very clear to them. They take wrong biopsies. You should never take wrong biopsies. Biopsy is the starting point for any treatment, and it gives you it gives a good start if you take a good biopsy. Now this is a depiction of how we stage the disease, the T disease staging, regarding the depth of invasion, involvement of surrounding structures. All these are important aspects to stage the disease. Now, staging the disease has 3 components. We told you: the local lesion, 2 the involvement of the lymph nodes, and 3 whether there are metastatic lesions or not. Taking these 3 into account, we can classify the disease, or we can divide the problem into 3 types. It might be an early disease, it might be an invasive disease or locally invaded disease, or it can be an advanced disease. So this is a bird's eye view of how we approach penile cancers. Early disease. What do you mean by early disease? T1A diseases, or diseases which are small in size, which are limited depth, and usually they are located at the distal part of the penis, usually affecting either the glans penis or the preputial skin of the penis. So these early and localized diseases have the ability to undergo therapies which are not disfiguring. Okay, what do you mean by disfiguring? Where we do not have to remove a part of the penis for treating them. We have options for these diseases so that we can preserve the functional capacity, we can preserve the entire length of the penis. So for these cases, for tumors that are distally located, small, less low grade, for them we can go for local ablation of the tumors or local excision of the tumors, or we can also proceed with topical therapy with drugs like 5-fluorouracil and others. To be very true, we in India do not advocate such measures upfront in the community it affects, because this requires a very rigid follow-up, and this requires regular other interventions also. So this is advisable for patients who are very aware, who are educated enough to understand the importance of regular follow-up, and who are ready to undergo further therapies in case of failure of this therapy. You've understood? These are local therapies, these are non-disfiguring therapies. We just ablate the lesion either by local excision or by laser or by drugs or by radiation also. There is something called mold radiation, where the radiation mold is placed on the penis. So there are multiple options for conservative management, not disfiguring the penis. Number 2, when the case is slightly more advanced and we have to go for a disfiguring treatment, we have to go for removal of either a part of the penis or complete penis. So we can either go for a total penectomy or a partial penectomy. So how do we decide that what kind of the level of excision of penis we will do to give the for a particular patient. So, if we go back to this picture, suppose the tumor is affecting. So what is very important in surgical management, cancer management, is especially in cases of squamous cell carcinoma, that we have to give an adequate margin of tumor free tissue along with the specimen. We should have a tumor free margin of the part that we are removing from the body. So, if we suppose we are removing this tumor, so we would prefer not to remove just from here. We would prefer to keep a margin of tissue, of healthy tissue, and then remove this part of the penis distal to this line. You understand? So, margin of clearance is important for squamous cell carcinomas. So, that becomes the most important factor regarding the decision whether we go for a total penectomy or a partial penectomy. How does it become important? If the residual part of the penis can become a functional unit to perform at least one basic function of aiming the urinary stream, then we can proceed with a partial amputation of the penis. If the residual stump after removal is good enough to aim the urinary stream to hold the meatus and aid in passage of urine, then we can proceed with partial penectomy. Some authors or some places, they have also thought of some sort of sexual activity, if it is possible, with the residual penis. That is often less secondary, and primary is the capability of to aim your urinary stream. So, anyways, there is debate, and I would prefer you to consider it as a functional part. The residual part should be a functional penis, so that we can utilize it. If that is not possible, if the tumor is located somewhere over here and removal of the tumor with a healthy margin will leave behind lesser than what we call the stump, then we proceed with something we call a total penectomy. So, we remove the entire penis. So, how does the patient pass urine when we remove the entire penis? We create a new urethrostomy, new opening of the urethra in the perineum. Okay. So, this is the surgical aspect of the local disease. Now, as I said, there is another very important aspect, and possibly the most important aspect in a case of penile cancer, is how to deal with the inguinal nodes. So, a patient can come to you with a mass on the penis and several other options regarding presence of lymph nodes. He can have no palpable lymph nodes or no discernible lymph nodes in the groin. He can have palpable but mobile few lymph nodes in the groin. He can have fixed, solid, large lymph nodes in the groin. Okay. So, you see this patient, he has a large and fixed lymph node in the groin. Can you see? I get no response from your class. That is actually very disheartening. Can you see this large lymph node over here? Okay. So, the lymph nodes can be like this, large and fixed. Lymph nodes can be small, palpable and mobile, and lymph nodes cannot be palpable also. There might be no palpable lymph nodes. So, the idea of a surgeon is to address the lymph nodes in some way or the others. Suppose you have a non-palpable lymph, there are no palpable lymph nodes in the groin, but a high grade penile cancer. That time we have the option of either doing a sentinel lymph node biopsy or a superficial inguinal lymphadenectomy. The idea is to check whether the tumor has spread to the groin or not. If the sentinel lymph node biopsy is negative for malignancy, or the superficial inguinal lymphadenectomy does not harbor malignant lymph nodes, then we can assume that there are no lymph nodes in the deep lymph node or in the pelvic groove. Okay. However, if these two are positive, then we have to do a complete inguinopelvic lymph node dissection. You get my point. The idea is to beat the tumor by one level of lymphadenectomy. If there is no spread, then we possibly do a sentinel or a superficial. If there is a spread to the sentinel or the superficial, then we do a superficial and deep lymphadenectomy. If there is a spread to the deep group of nodes, then we do a pelvic lymphadenectomy as well. So we do one step further lymph node removal to give cure to the patient. Have you understood? So uh, this is for early cases. For advanced cases, it might be necessary to give chemotherapy to the patient to downstage the disease before we proceed with addressing the groin nodes. Now, regarding prevention of penile cancer, preventive there is an upcoming concept of a vaccination, HPV vaccination. Can you tell me HPV vaccination is more prevalent for which cancer? Have anybody? Very good. So it is advisable for all of you to get cervical cancer vaccinated as well. This is it is working very well nowadays. It is advocated for all women now. Cervical cancer vaccination should be taken. So it has been utilized or tested for penile cancers as well. Neonatal circumcision, good hygiene, avoiding tobacco, and early evaluation of lesions. So these are in a nutshell what you can do to either prevent or early diagnose a penile cancer. To testicular cancer is slightly different. So did you get an overall idea regarding penile cancer? If the patient comes to you with a lesion, you get a good biopsy, you investigate whether the patient is having lymph nodes or not, and then treat the local tumor by either a partial or a total amputation, followed by surgery to address the groin and testicular tumor. This however is not as uncommon as the penile cancers. This is more prevalent, and these tumors of the testis are found in the pediatric population, in the middle ages as well as in the elderly. So this is a solid neoplasm. What is a testicular tumor? We designate solid growths, solid neoplasms of the testis, and this is the most common. This is very common in the middle age group. Okay, and what is the most common type of testicular tumors? Germ cell tumors. So, testicular tumors come with a list of risk factors. The most important among them is cryptorchidism. I had gone through cryptorchidism with you, undescended testis with you. So, testicular tumors, undescended testis, an intra-abdominal testis harbors the maximum chance of malignant transformation. An inguinal testis harbors lesser chance but more than the normal population. So, there is direct correlation regarding the level of descent to malignancy, to testicular malignancies. Okay. So, testicular tumors are mainly classified into two types. It is either a germ cell tumor or a non-germ cell tumor. Germ cell tumors are of two types. It is a seminoma, which is the most common tumor, or it can be non-seminomatous tumors. There are multiple varieties of non-seminomatous tumors like the embryonal cell tumors, yolk sac tumors, teratomas, choriocarcinomas. And non-germ cell tumors are also of various types. The two commoner variants are the Leydig cell tumors and the Sertoli cell tumors. Okay. So, we need to know about how this happens. So, every embryo harbors a certain kind of cell that we call as a totipotent cell. So, what do you mean by a totipotent cell? It can give rise to any cell line. So, totipotent cells give rise to germ cells which eventually lead to formation of spermatocytes, spermatozoa, etc. So, any cells, any totipotent cell in these lines, if there is abnormal maturation, abnormal progress of development of these totipotent cells, it gives rise to totipotent malignant cells. Such a malignant cell is an embryonal cell. Okay. This embryonal cell can give rise to seminomatous development or a non-seminomatous development, and it leads to all these types of germ cell malignancies in the testis. Okay. So, just like the penile cancers spread via lymph nodes more frequently, these tumors also uh, they spread by lymph nodes. Now, where does the testis embryologically originate? Retroperitoneum, inside the abdomen, and then it descends. So what happens is that the spread to local lymph nodes in case of testicular cancers are designated to the abdominal lymph nodes, to the para-aortic lymph nodes, to the retroperitoneal lymph nodes. So local lymph nodes in case of testicular cancer is not the inguinal lymph node, it is the para-aortic or the abdominal retroperitoneal lymph nodes. Okay. So these also spread hematogenously to lung, liver, etc., etc. But what is important is this is also important for your long cases, that how does a patient with testicular mass or testicular tumor present? Most testicular tumors are asymptomatic. They don't give rise to any symptoms unless the patient himself or the sexual partner of the patient identifies a swelling or a lump in the testis. So, in this case, an early diagnosis can be made by local examination of the scrotum by the patient or the partner. But nowadays it is prevalent, but a lot of people miss out on the diagnosis. So, in spite of harboring a testicular mass, people do not get to know that they are having a disease. They come with some other problem. What is that problem? What is the most common presentation of testicular tumors? Very commonly you will see a patient with a large abdominal mass, and you will think of 2000 differential diagnoses, but it eventually, if you don't examine the testis, you will not know the primary at a clinical level. So it is essential for every male patient with an abdominal lump, abdominal mass, to check the presence of both testis in the scrotum and to check the presence of a testicular mass in the scrotum. Okay. So mass abdomen is a very common presentation. Other than that, scrotal heaviness, dull ache, etc., etc. These are all the common representations of a testicular tumor. So, how do you diagnose and how do you evaluate this patient? How do you confirm that it is a testicular mass, a solid mass? So, at a clinical level, what can you do? Clinical level, I am saying. Obviously, the ultrasound is there to help you, but the patient has come to you and he is paying you certain amount of fees to get an opinion that, doctor, what has happened to me. So your face or your attitude after a clinical examination will probably give the patient some idea whether it is something to be scared of or it is very benign. So how do we differentiate that? Usually a solid, yes, getting above the swelling will differentiate it from a hydrocele with a hernia. Okay, good. So hydrocele is also testicular swelling. Now, what differentiates a hydrocele from a testicular mass? What is the basic difference? Very good. Transillumination test. So transillumination, we will get a solid, we will get the shadow of a solid mass in a testicular mass. Any other thing you know, transillumination test can also diagnose anything. The good, I mean, the one of the easier diagnoses with the transillumination test is that of an epididymal cyst. Epididymal cyst has a very Chinese lantern pattern type of transillumination if you do a torchlight examination. Anyways, there is one more very important thing that you can diagnose clinically to differentiate between a benign and a malignant affection of the testis. That is called testicular sensation, testing for testicular sensation. Do you know what is testicular sensation? Testicular sensation is that if you grab the testis and apply pressure on the testis, then there is a nauseous feeling for the patient. Okay. So, testis affected by a malignant disease usually affects probably the nerves surrounding it, and this testicular sensation is lost in cases of malignant diseases. You understand? So, there are two things I have to first decide whether this is a solid mass or a cystic mass or just fluid collection in the testis. And একটু বলে দিন তো, ক্লাস নিচ্ছি, ক্লাসের পর আসছি ওটিতে। And then with the testicular sensation test can guide us to, it can give us an idea whether it might be a malignant disease or not. Yes. No, then it's normal. The sensation is preserved in normal cases and it is lost in possible malignant cases. So, how do we evaluate this patient? How do we take a biopsy in this case? And what do we do? Biopsy can't be taken. Anybody else? So, first we have to do a serum marker study to give us an idea whether this might be a non-seminoma tumor or not. Before doing anything for a testicular mass, serum tumor marker study is very important. And in case of a testicular mass, wedge biopsy or any biopsy of that sort is not done, but a biopsy is definitely done. We need to have a histopathological confirmation of malignancy. So, how do we get that confirmation? No, sentinel lymph node biopsy will not give you a confirmation of the disease present. It's not done for testicular masses. So, we need a biopsy from the source of the tumor. Taito. So, how do we get that biopsy? We do a kind of orchidectomy, which is a special kind of orchidectomy. Where is the testis present? Testis is present in the scrotum. To remove the testis, it is very easy to cut open the scrotum, take out the testis and close the scrotum. But we choose not to do it in cases of suspected tumors of the testis. What do we do instead? We do something that we call a high inguinal orchidectomy. What do? We open up the inguinal canal like we do in hernia surgeries. Have you ever seen a hernia surgery being done here? You've seen. So, we open up the inguinal ligament, we retract the testis from the scrotum into the inguinal region, we clamp the vessels and the cord so that there is lesser chance of dissemination of suspected disease, and we take out the testis from the groin. This is called high inguinal orchidectomy or a radical orchidectomy. Why? What is the thought behind this? That we would not involve a local structure to get contaminated by that disease. What do we mean by local structure? See, the testicular tumors have a lymph nodal spread to the retroperitoneal nodes, right? But the scrotum has a spread to the groin. So, if we violate the scrotal skin in the process of taking a biopsy, we would contaminate the scrotal skin, and in case of spread, this tumor would spread to the groin nodes as well. So, the idea behind this is not to violate the scrotal skin by any means. We will not do an FNSC. Please don't mention FNSC or core biopsy for testicular tumors. I know, in spite of telling you this, 8 out of 10 will go and tell in the examinations that we will do a fine needle biopsy. It is my personal experience. 8 out of 10 people go and say that we will do a fine needle biopsy. We do not do a fine needle biopsy. We do not do a core biopsy. What do? We do a high inguinal orchidectomy to confirm the presence of malignancy or not. Okay. So, after a high inguinal orchidectomy, we get to know whether the tissue, whether this suspected mass was malignant or not, and what kind of malignancy, whether this was a germ cell tumor, whether this was a non-germ cell tumor. And before doing this orchidectomy, we had done the serum tumor marker levels. Now, if any of those marker levels were increased, we would repeat the marker levels after 1 or 2 weeks after removal of the testis. Why? We would want to see whether the marker levels have dropped after removal of the suspected lesion. Why? Because if the marker levels are still raised after removal of the lesion, then possibly there are other sites where it has already spread. Okay. So, after getting a confirmation that this is this is a malignant disease, we do two things. We do a repeat marker study and we do CT scans or MRIs to designate whether there is any lymph node spread in the abdomen, retroperitoneum or not. Okay. So, from now on till now, the management for a germ cell, please do not talk so loudly, I am not liking it. So, till now the management of germ cell and non-germ cell tumors were absolutely the same. We take out the testis, we do a marker study repeat, we evaluate for presence of retroperitoneal lymph nodes. Then if we have a germ cell tumor or if we have a seminoma and if we have a non-seminoma, the treatment becomes different for these two. Okay, so what happens? For seminomas, it is said that they are very radiosensitive. Okay. So, if you see, if you have a patient with a seminoma after orchidectomy, you find that the patient is having retroperitoneal lymph nodes. What will be the next treatment strategy? The next treatment strategy will be to give radiation to the patient. Okay. So, what kind of radiation do we give to these patients? So, do you see this pattern? Para-aortic, I mean the retroperitoneum midline part and one side of the abdomen. Okay, so this designates on which side of the testis is involved, and this pattern of radiation field, it is often called the dog leg radiation. Do you see? Do you find that picture? It's a dog leg radiation. Why it is called? Because dogs often lift up one leg to pass urine, and then one leg is on the ground, the one leg is lifted. So, this is often called for that reason a dog leg radiation. So, for seminomas, the go-to treatment is radiation and not surgery. Often, if there is a residual mass which is more than 3 centimeters in size after completion of radiation, then we have to see whether this residual mass is actually harboring malignancy or not. For that, we do two things. We do a PET CT scan and we take a biopsy to confirm that the residual mass is actually not fibrosis but residual malignancy, and then we proceed for a retroperitoneal lymph node removal. This is in case of seminomas. Whereas in case of non-seminomas, the go-to treatment is chemotherapy and surgery. So, if the initial lymph nodal mass is small in size, then we can go for an upfront retroperitoneal lymph node removal. If the mass is very large in size, then we can go for a chemotherapy cycle of 2 to 4 cycles of chemotherapy with bleomycin, etoposide and paclitaxel. This is a wonderful response these patients have with this regimen, and after giving them 2 to 4 cycles of chemotherapy, then we proceed for retroperitoneal lymph node dissection. So, seminomas and non-seminomas have very different treatment strategies. Okay, so if you get a question on seminomas, be sure to make this classification in your treatment, because that is what teachers are looking for, whether you know that all testicular tumors are not treated similarly. These are two very different diseases. Okay. So, how do we then follow up? We follow up the patient by regular imaging to look for recurrence of lymph nodes, and we do regularly the lymph node the tumor markers to see if there is an increase in the trend of tumor markers or not. Okay, so this is in a nutshell, and this is basically the strategy for treatment of testicular tumors. So, this I showed you. Testicular tumors are, they respond very, seminomas respond very good very well to radiation, and non-seminomas respond very well to chemotherapy. And surgical skills for retroperitoneal lymph node dissection, although a high demand surgery, but it has very good results in high volume centers. Okay. So, what is this? You will have, I think, 25 marks allotted to specimens, surgical specimens in your examination. You have to describe the specimen. How do you describe a surgical specimen? So, very good. So, you need to know how to describe a surgical specimen and then go back to answering the question. The main idea is it's clinically very important for every physician in the country to know how to deal a case of acute scrotal pain. Okay. Why? Because as you see, I have taken up urology as a branch. One of the primary motives of urology was that it hardly has any emergency. Like a trauma surgeon, like a neurosurgeon, you have to be on your toes to run to the hospital whenever and wherever they call you. That is not so for us, because we all cases, in all emergencies, there is time, and even if you are there on field after passing your MBBS, I can give you certain instructions to tide over the night, which is true. Whereas there are only a few scenarios in urology where you don't have any time, where time is precious. And one such patient is a patient with acute scrotal pain. Okay. So, how to treat a patient, how to approach a patient with acute scrotal pain? So, we are basically talking about torsion of the testis. This is a urological emergency, and this is very common. This has two ages of presentation. It is present in the neonates. It can present in the neonates as well as in the adolescent age group. Okay. So, what happens exactly in this? What happens is that there is a torsion of the testis around its axis. Why does this happen? Because what we call a bell clapper deformity is very often responsible for such a torsion in the testis. What happens in a bell clapper deformity? What is a bell clapper, do you know? ঘন্টার ভেতরে যেটা দুলছে, that is a bell clapper. So what happens in that? Why is that so mobile? Because that is free on all sides, and it is not attached. It is attached only to one end in a enclosed cavity. So you see in this picture, the first picture, the testis hangs by a leash of blood vessels and the epididymis. This epididymis is going down till this part of the scrotum, and then the testis is attached to the scrotal wall by a leash of tissues called the gubernaculum. Okay, and the tunica is free only on one side. The other side is covered by the epididymis and it is fixed by the gubernaculum. This is the normal orientation of the testis. Okay, so for some people, what happens is that this tunical covering extends on all sides of the testis. The tunical covering basically gives free mobility to the testis, because the tunica it is a smooth layer and it can rotate easily. So the high riding nature of the tunica on all sides of the testis gives it the appearance of a clapper inside a bell, that it is not fixed to any place inside the scrotal wall. This deformity in certain scenarios, say an acute trauma or a very some event which causes a very tight cremasteric reflex, all these things might suddenly pull up the testis, and this pulling up in presence of free mobility might lead to a torsion in the testis. What happens is the axis from this, in cases of a bell clapper deformity, the axis shifts to a horizontal axis instead of a vertical axis, and it makes the testis more mobile on that front. So this happens, and there is a twisting of the cord. Initially the venous occlusion happens. This venous occlusion leads to engorgement of blood, and then the arterial occlusion happens, and then progressively ischemia takes place. All these things are time dependent and it leads to the dramatic necrosis within 6 to 12 hours time. So, we have a very short window period to act upon this case. Now, every patient, every young boy, every neonate that comes with a scrotal pain obviously does not have torsion testis. So, there are other mimickers of torsion testis, right? So, what are those mimickers of torsion testis? Epididymoorchitis. Anything else? Torsion of other smaller structures in the testis, torsion of the appendix of the testis. There are other things that can also give rise to acute scrotal pain, but what you rightly said, that there are two basic differential diagnoses that we need to differentiate clinically to start therapy as early as possible. So, we need to differentiate between this, if I give a list, but on that particular day this. We need to differentiate between acute epididymoorchitis pain from a testicular torsion pain. How do we do that clinically? There are a few clinical parameters that we need to assess to give us that idea. One is, in case of torsion testis, the testis will be high riding. Okay, why? Because there is a torsion in the cord. So, once we twist the rope is pulled up, right? So, the testis will be high riding. Another thing I mentioned, that the orientation of the testis will probably not be vertical but be horizontal, right? So, these two factors plus the most important sign is that when we give support to the testis, when we give support and raise the testis, the pain increases in case of testicular torsion, but it decreases in case of epididymoorchitis. Okay. So, this is called the Prehn's sign. Prehn's sign, this is very frequently asked in your examinations. How do you differentiate a acute scrotal pain? Frequently, epididymoorchitis patients might have associated fever with it, features of urinary tract infection with it, and both the patients might come with vomiting episodes, etc. So, it is very essential to differentiate between these two diseases, because for an epididymoorchitis all you need to do is to provide a constant scrotal support and advise antibiotics, whereas for this patient you need to take him to the OR immediately, and I mean immediately. Okay. So, by clinical examination you need to do this. How can we confirm this? We can confirm this by doing a color Doppler ultrasound of the scrotum and to assess whether the blood supply to the testis has been cut off. A color Doppler examination gives us a confirmatory diagnosis, but living in a country like India at 2 o'clock in the night, you will, sir, 2 minutes. Sir, 2 minutes. You will probably not get the opportunity to perform to access a color Doppler. So, in that case you will have to rely on your clinical skills and make a diagnosis whether the patient is having an epididymoorchitis or a torsion testis, and it is better to err on the surgical side. If you open an epididymoorchitis, you are doing no harm to the patient, but if you do not take a torsion testis to surgery, you are making a criminal negligence. Understood? So, what is the treatment protocol? How do we treat this patient with torsion testis? Immediate surgery is the only answer. And what do we do in surgery? We explode the testis. To see the viability of the testis. How do we assess for viability of the testis? We see the color of the testicular tissue, whether it is pink and supple. Okay. If it is black, then it is probably necrotic. If it is pink or if it is reddish, then it has congestion and there is chance of survival. So, what do? We manually derotate the testis. Okay. So, after derotating the testis, we put hot compress with hot mops and we try to increase the vascular entry into the testis so that there is a chance of rejuvenation of the testis. Once this happens, at the end of our assessment, if the testis is once again pink and supple, then we preserve the testis. And what do? We fix the testis on 3 points inside the scrotal wall so that there is no further rotation of the testis. Okay. But if the testis is necrotic, then we have to proceed with orchidectomy. And what do we do for the other testis? Because if one testis is has a history of torsion testis, then the other testis is also predisposed to a similar condition. So, for cases with testicular torsion, we fix the other normal testis as well. A 3-point fixation is advised. Okay. So, my intention was to make clear how to differentiate clinically between epididymoorchitis and testicular torsion, and how important is early recognition for torsion